share my slides. We'll start from the beginning. Okay, so thank you for coming today. This is a brief introduction to paediatric spirometry for people who work in primary care. So my name is Emma Ray. I'm a clinical practice educator for children's asthma for Hampshire and the Isle of Wight ICB. I'm going to be finishing that role in a couple of weeks and going back into primary care. So I'm a respiratory nurse specialist by background, but I will still be around and in different formats. So I won't be going away anywhere soon. So, sorry. Right, so today I'm just going to give a brief update about the National Bundle of Care for Children and Young People with Asthma, a little bit about the local guidelines, thinking about practical considerations in spirometry, how you perform it in children, how you interpret it, some examples, and we'll have hopefully have some time for questions. But if you've got questions, as I say, as we go along, just go ahead and ask, that's fine. I'm having trouble getting this to the next slide. Okay, so yeah, the National Bundle of Care, hopefully all of you would have heard of this. So it stems from the National Long-Term Conditions Plan. Obviously, there's been an update on that in the last year because we've got a new government, but it's all about improving the care and outcomes of children and young people with asthma because we've got some of the worst outcomes compared to the rest of Europe. So that's in terms of hospitalisations and deaths. Just to say, in Hampshire and the Isle of Wight, there's only been 4 deaths in the last 10 years. There's not loads of children dying from asthma, but obviously that's something we want to avoid. So we've been working on a number of different projects, so thinking about environmental impacts, early and accurate diagnosis, so that's why this is important, effective preventative medicine, managing exacerbations and severe asthma, so lots of things on that. I don't know why I can't turn this. Sorry, I'm just going to share that again. It's gone a bit mad. That's the trouble with Teams. Right, okay. Okay, so getting the diagnosis right in children is really, really important. We want to make sure that they've got the right diagnosis so that we're avoiding asthma attacks, deaths and hospitalisations. If we don't get the diagnosis right early on, what can happen is you can have it can lead to long-term lung damage. So the airways become remodeled because of the airway inflammation, that damage, you get scarring of the lungs and you can get impaired lung growth. It can affect their quality of life. So if they're having time off school because of breathing problems, the parents as well might need to take time off work. It could all be very problematic. And definitely parents want these tests to confirm the diagnosis to make sure, that they're getting the right treatment for their child. And this, once they've got that diagnosis and it's been reassured that child has got asthma, then that may help the parent to be a bit more adherent with their medications as well. So we're expecting parents to be delivering the medication, supporting children with their drugs. But a lot of people with asthma who may be coded with asthma don't actually have asthma. So we need to make sure we are definitely getting the diagnosis right. So we might think it's asthma, but is it really? So it's really important to check that history, make sure that we're offering diagnostic tests, because if we're offering them asthma medications, the asthma medications themselves might not be the right treatment for that patient, and the potential side effects. We could have missed a diagnosis. The inhalers can be very expensive as well, and there may be a cost implication to those inhalers. So we don't want to get things wrong. So offering diagnostic tests early on is really, really important. Sorry, I'm struggling to change this. I think I've worked it out now. So for Hampshire and the Isle of Wight, provision for diagnostic services for children is very patchy and it's not very joined up at the moment. As you're probably well aware, there was a local incentivised scheme that the ICB developed a couple of years ago in order to get GP practices going on their spirometry post the pandemic. So GP practices get paid a lump sum of money for each spirometry test that they do, and that program of work included everybody over the age of 8, so everybody inclusive the 8 years old. So if in a GP practice you could deliver spirometry to children aged 8 and above, you get that payment. So a lot of people are doing it in adults, obviously, to get that payment, but they're not doing it so much in children. But just to make you aware, if you're doing it in children aged 8 and above, you'll get that payment from the ICB. If you're on the Isle of Wight, you're really, really lucky. They've got an amazing diagnostic centre over there in St Mary's, and they offer full lung function testing to children and adults. So that would include pheno and spirometry. Andover Community Diagnostic Centre, some of you may be fairly close to that, but I don't think many of you are. But they have just heard that they've received some funds from NHS England to open paediatric spirometry services in the very near future. So that will be coming very soon, probably this year. Royal Southampton, they're open to adult spirometry and pheno at the moment, and they're considering peds, but I'm not sure they're going to put in any bids for funds this year because they're very new and they're a bit nervous about opening too much too soon. And if you're from Portsmouth, they haven't even built their community diagnostic centre yet, so that's coming next year. So I'm not sure what's going on with the paediatric spirometry yet, but we will probably contact them and get them to include that in some of their bidding. So as you're probably aware, there was some new nice guidelines that came out the end of last year. This is the algorithm they produce for children aged 5 to 16. So in there you've got pheno right at the beginning. So if you're very lucky and you've got a pheno device alongside a history that sounds like that patient might have asthma, if their pheno levels are over 35 parts per billion, then that would be conclusive of a diagnosis of asthma. Secondary to that, you would move on to spirometry with reversibility. And then after that, you've got peak flow variability testing. So peak flow variability testing, there's very little evidence to say it's very useful, but they've kept it in here because the GPs were very keen to keep it in. Obviously, it's probably more of a historic test that GPs are familiar with doing. Some people find it useful. If you've got an older guy who's an engineer who likes doing charts, they might do it very, very well. But if you're expecting a parent to do it with a young child, they might have a busy lifestyle. You can't guarantee that they're going to do it very well. They may also just fill it in on the day that it's needed to be handed back. So it's not the best objective test, I would suggest. At the end of this flow chart, you've got skin prick testing or blood tests. But just to make you aware, these tests, obviously, skin prick testing is only available in the hospital setting anyway. We wouldn't recommend you doing blood tests for children. These are just allergy tests, and the jury's out on actually whether this should have been in this flow chart anyway from the paediatric world. So the tests aren't perfect, but that's what NICE has come up with. So for our local guidelines, again, we've gone for pheno at the top, so 35 parts per billion, and then spirometry. If they can't do spirometry, we'd say reattempt every 6 to 12 months. If they can do spirometry, we would suggest you use the lower threshold of 10%, and that's comparing it with your predicted value rather than the pre-FEV1 when you're calculating that. And I can share a calculator with you after this talk that you can use. If they meet that criteria, then you diagnose them with asthma. But if there's no reversibility, you can look again at the pheno. If it's over 25 parts per billion, and this is based on European Respiratory Society guidelines, with that history of possible asthma and maybe some other evidence that they've got peak flow variability, then you would suggest they might have asthma. But if you've got an obstructed spirometry and there's no reversibility, then do refer in. We've got in there a trial of treatment. So, you know, some people can't do spirometry, so adults and children potentially can't do spirometry. So if that is the case, then you would offer them a trial of treatment. So in the 6 to 11-year-old age group, it would be low dose inhaled corticosteroids, so something like Clenel 50 2 puffs BD, and you give them a salbutamol inhaler. But if they're over 12 years old or 12 and above, then you'd start them on the anti-inflammatory reliever inhaler or a MART regime if they had more frequent symptoms. Hopefully that makes sense. So these are the current guidelines. They're just going through a little bit of process of update at the moment. So for this 6 to 11-year-olds, step 1 is going to be a low dose inhaled corticosteroids. So this is what you'd be using for your trial of treatment. In the hospital here, they do use Pulmicort as the preventer inhaler alongside the Sanomol PMDI. Obviously, they're two different types of inhalers, which isn't ideal, but there's no evidence to suggest that a dry powder device is safe to use in this age group. So please don't give dry powder reliever inhalers to this age group at the moment until we've got enough evidence to suggest that's okay. Saying that, if they had established asthma, you can step them up to Symbicort. So it's a low dose Symbicort that you would use as MART. So your usual regimes there, so 1 puff BD or 2 puffs once a day, up to 8 times a day, and you can use it in an emergency. Montelukast is on there as well if you think that would be useful. And if they're poorly controlled after this, you would refer into secondary care for a review. So you're always aiming for no symptoms in asthma. And that should be the message we're giving to our patients and families. For your 12 and over age group, you're going to be starting them on your Symbicort reliever inhaler. So that's the anti-inflammatory reliever inhaler. It's a higher dose, so just be careful with your dosages. If you're giving it as a reliever inhaler, it's the 200 over 6. But if you're starting with MART, go with the lower dose, it's the 100 over 6. For some children, they might not be able to use the dry powder device, but most children can use a dry powder device. It just needs a bit of extra training. But the Symbicort does come as a metered dose inhaler, but just be wary about using it because it's very high doses of steroids, because you can give it up to 12 puffs in a day. Obviously, stepping up, once the asthma is established, you can add in Montelukast, and the Spiriva Respimat is going to be in the guidelines as well. But if they're still poorly controlled after medium dose inhaled corticosteroids, you need to refer them to secondary care. So getting to the main point of the presentation, so spirometry, it's just a measurement of lung volumes, isn't it? Based on height, age, your gender, and it will be affected by environmental factors, your ethnicity, whether you are premature, and how well you do the test. So on the day of the test, if you're not feeling your best and you're not putting the effort in, there may be, it may affect the results. What it does is classify the type of ventilatory defect, so whether a person has obstruction or restriction, or whether they've got them both at the same time. And it can tell us whether there's a response to a bronchodilator, so as in salbutamol testing. It can exclude the presence of a lung disease alongside a clinical history. So if you've got obstruction and you had a smoking history, it doesn't automatically mean that you've got COPD, so just be aware of that. There can be other reasons for obstruction, and we use spirometry to monitor disease progression, so in asthma, cystic fibrosis, and in COPD. As with all tests with asthma, unfortunately, they're not perfect, and on the day of the tests, it's it's estimated that approximately 50% of all patients will have a normal spirometry. And particularly if they've started treatment anyway, it might be completely normal. So on a different day, you might get a different result. That also reflects the variability of asthma. So you have good and bad days in asthma. Sometimes you can be absolutely fine, and then your asthma gets worse. So if you are considering doing spirometry on a person, try and get them when their asthma is not quite as well controlled as it could be. So if they had seasonal asthma, maybe think about that. Obviously, it all kind of depends on when you can fit them in at the end of the day, but just to bear that in mind. So similarities in compared to adult spirometry. So the way you'd set up the equipment, obviously they're going to be the same. The salbutamol dose is the same. Do any of you do flow volume loops?
No.
No. Okay. So some people have done some training local to here and have been taught how to do flow volume loops. So you can still do those if you've been trained to do so. You're doing forced maneuver techniques. That's exactly the same. We would say using a nose peg is advantageous. I know I was having a look at the ARTP website yesterday, and it says it's not mandatory, but we would say in lung function departments, they all use nose pegs because you can get a little bit of leakage with your forced manoeuvres. And the way we interpret it, so the Z scores and the severity grading is exactly the same as well. So the differences is you're going to talk to them a bit differently. So you want to make it fun. You don't want to be strict and scary. It's got to be a really nice supportive environment to get them to do the test really well. We don't do the slow vital capacity in children. We find that if you do both tests, if you do the slow or the fast blows, it can confuse the children. And actually, when you're doing the forced blows, it's much, much more useful to get those values rather than the slow blows. Children can empty their lungs really, really quickly. So what you can find is they'll go really fast at it. So, some older people, they can take quite a long time to empty their lungs. This can be the case in some children, but generally they can empty their lungs really, really quickly. There's no maximum amount of blows either. So in adults, we talk about, you stop at 10 blows, 10 fast blows, but in children, you can keep going. Obviously, you're going to keep an eye on them, make sure they're not getting upset and not getting fatigued. So, that's really important that you're keeping a close eye on them and stop if you notice, there's a change in how they're feeling. So the reversibility criteria, so we would say try and use the predicted value to do your calculation. It's a much more sensitive calculation rather than just using your 12% improvement from your pre to your post values. The calculation is there, so basically just it's the post minus the pre, times 100 divided by your predicted FEV1 value, and that will give you a result. And it's just a bit more sensitive. Referral if they're obstructed, so the paediatric teams want to see children who've got obstructed spirometry, just to keep a bit of a close eye on them. And if they're restricted or their FEV1 is reduced or they're not reversible, and it's unclear what their diagnosis may be. Bacterial viral filters, some children obviously got smaller mouths than adults, so you might want to invest in some oval shaped mouthpieces that might be more comfortable, but I have seen children using mouthpieces that have just got the O-shaped mouthpiece and they seem to get on okay. The paediatric ARTP certificate, you can get this, it's not mandated. So none of the ARTP qualifications are mandated at the moment. I think if you've done some courses in spirometry, you feel confident to do it in adults, you may have got your ARTP qualification. It's not a huge jump to do it in children. So don't worry too much about achieving the qualification. But if you really want to, obviously that would be fantastic. But we're all busy people, don't we know? And if you've got other things you need to be doing that take priority, then concentrate on that. And I put just down the end there, children don't faint. So sometimes we see adults sort of having a vasovagal, don't we? And it's all quite dramatic, but luckily children don't faint. So that's a good thing. So infection control considerations, just a reminder here, make sure you've got the windows open. You should be using a filter mouthpiece. And people, there's still COVID going around, so just be careful about yourself. Make sure you're vaccinated. Keep away from the patients. When I was doing spirometry yesterday, and a gentleman was coughing everywhere, despite the fact that we asked him to cough into a tissue. So just be really careful. And when you're booking patients in, assess the suitability of the patient. So this could be for children and adults, but with children, just check whether they potentially have any learning difficulties, autism or ADHD. You can find that there seems to be a lot of children these days who may be on the spectrum. They may be a little bit more sensitive than some other children. So you just may need to handle that slightly differently, and you can offer them longer appointments. I can't remember the name of it now, but there is people who are neurodivergent should be offered longer appointments, or appointments that fit with their the way that they would react, so that they feel comfortable when they're coming into the NHS. You might also want to consider if they've got any neuromuscular problems as well. That's less sort of common in children, but you never know. But confirm with the parent or guardian that the child is going to be able to follow those instructions anyway. So have a conversation beforehand to make sure there isn't going to be any problems, because you don't want a kid coming in who's potentially not going to sit still for very long, or maybe get quite upset and angry. It's just something to consider. And potentially children, they're relying on their parents to bring them in, but sometimes parents have got hectic lives. There could be problems at home, but if they're not brought in, we need to document that and escalate it if there's an issue there. And if they're not coming in multiple times, then we need to be reporting that and doing something about that. So prepping the patient as you would normally do, message them, give them the pre-test instructions. So you're probably all very well aware of all these types of things. For a child, if you're doing it after school, particularly if it's a boy, they might be coming out of school running around doing all sorts, aware that could affect the test. So try and counsel the parent on trying to keep their child less active just before the test. Contraindications, again, they're all the same as you would expect in in an adult. So things that you may come across more are chest infections, eye surgery, or problems with their eyes, middle ear infections, having an upset tummy or feeling sick, those sorts of things. I have come across a child who had blood pressure problems. That's quite interesting. So yeah, I would go through all of these things anyway, just to double check. So preparing for the clinic, you're going to calibrate it as normal. Just make sure you're getting your equipment calibrated every year, sending off the syringe if that's what you do. If you're going to do pheno, you should do it before doing spirometry, not after, because doing the forced blows can affect the pheno results. But if you need to do it afterwards, just document it. And your quality checks, you're going to be doing a calibration verification at every clinic. Make sure you're using your GLI reference values on your spirometer. So if you go into settings, do check those. Hopefully yours are all up to date. And if you don't have the GLI references, contact your manufacturer of your spirometer. Your spirometer should also show the lower limits of normal or Z scores, because that's the way we interpret spirometry these days. and thinking about physiological controls as well. So I don't think everybody's doing physiological controls. So but have a look at the ARTP website about how you would do that. It's usually 2 weeks of readings. It can be really useful though if your spirometer is giving erroneous results. If someone can check it against their own lung function to see whether it correlates to that, that can be really, really useful to do. And that's the point of it, really, just to check the machines are working. Washout periods are all the same. You should all be aware of that, and that's what you'll be counselling the patient and the parent before they come in for the appointment, if you're doing reversibility, and do their height and weight. Obviously, children are growing all the time, so you must do the height and the weight on the day of the test. You can't just use a recent result. So you make sure they're standing up nice and tall, heels against the wall, chin down slightly, and you measure the top of the head, right on the crown of the head, to get their weight. So our role was basically to get them to do this test correctly, and that's by giving them the right information in a simple format and being really enthusiastic to get the best out of them, basically. So performing the tests, have a think about your environment. It can be quite a nerve-wracking experience for a child to come into a hospital setting or a GP practice. If there's lots of equipment around, could you tidy it up, or could you just make it look a bit nicer, so that they're less intimidated? If they can't do it on the first test, they might benefit from coming back and doing it a second time, so then they've got familiar with the setting. And what I would do is, when I'm talking to a child to get them to do it, to sort of prepare them, I'd let them put the mouthpiece into their mouth and try the nose peg on to make sure it doesn't feel too uncomfortable for them. I talk to them about, what we're going to do in the test. So you're going to do some fast blows before and after some of the blue inhaler. What you'll do is take a really deep breath in, then you'll pop your teeth and your lips around the mouthpiece, and then you're going to blow as hard and as fast as you can, and keep going until you're completely empty. And I could show them that on my mouthpiece as well. It's useful to have a mouthpiece there. So it's got to be really clear and simple information. Don't use too many words. And visual incentives can be really good. So if you've got on your spirometer device, you should have some cartoons that you can use. Has everyone seen those, or has people need to find them? If you struggle to find them, let me know and I can help you find them. Otherwise, you can contact the manufacturer of your spirometer device. Sometimes it can be useful. Sometimes actually children will just do it with the coaching. So it can be useful and it cannot be useful. So again, positive coaching throughout. Just make it as fun as you can. Be enthusiastic. Unfortunately, sometimes parents or their guardians can interject and sort of start coaching the child, which can be a bit difficult at times. So managing that can be tricky. But you just got to be polite and say, if she just follow, if the child can just follow what I'm saying, I'd be very, very grateful. Because you don't want the child getting upset if the parent sort of nagging them to keep going and things like that. But keeping an eye on the child to make sure they're not distressed or they're tired is really, really important. So they might need to do the test again. So we don't want to put them off at this early stage. So do stop the test if necessary. It's not about getting results at any cost. So the test procedure, this is a bit wordy, and I'm sure you're all doing this anyway. So a bit like what I said earlier. So it's if you're doing tidal breathing, those flow volume loops, they can be on the mouthpiece beforehand. But if not, you just ask them to take a really deep breath in, filling up their lungs as much as they can, and then blasting it out as fast as possible. You can use phrases like sucking on a straw, blowing out birthday candles, and keep blowing, yeah, and you keep guiding them, wouldn't you, to keep blowing to full expiration. So you don't need to be shouting at them. You just keep going, keep going, keep going, keep going until you're completely empty. That's fantastic. And obviously giving them positive feedback. You're doing really well. We just need a few more just to get there. So minimum of three attempts, and that's the same with adults, and checked for acceptability and repeatability. There is a little video there that I can share these slides with you, and you can have a look at that video another time. So the reversibility test procedure is exactly the same. So you're given 400 micrograms via a spacer device. They could use their own spacer, so it's a good opportunity just to go through inhaler technique with them, or you can use a disposable spacer. I always say hold it like a sandwich. So you've got your fingers and your thumb on the white bits, because it tends to fall apart, doesn't it? So if you get them to hold that, I usually say to them, we're going to have 4 puffs of the inhaler now, one at a time, and I'm going to shake that inhaler between each puff as well, just to remind you to do that. So what you're going to do is breathe out all the way. Pop your lips around the mouthpiece, start breathing in, nice deep breath in. When you breathe it in, I'm going to press the inhaler, keep breathing it in all the way, hold your breath 10 seconds, and I'll count to 10. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I'll shake the inhaler again, and we'll do it all again. So 4 puffs of that. Time the 15 minutes. And record the number of doses you've used in your salbutamol inhaler. So there's only 200 puffs in there. It will continue to fire even when there's very little medication in there. So you might find that some patients come into you and say, oh yes, when my inhaler's running out, I can really tell there's not much left in there. So you want to make sure that in your reversibility tests, your patients are getting the correct dose. So make sure you're looking at that. Wipe down your inhalers, so the canister and the outer casing with your green Clenil wipes are equivalent in between your patients. And think about how you might sterilize that inhaler if you're using it for multiple patients. So at University Hospital Southampton, they use the same inhaler for repeated patients, and what they do is sterilize it at the end of the week so that they can use it the following week. So your reversibility criteria, I've mentioned that. So you can use the 12%, which is mentioned by NICE, and that you don't have to have a volume for children. It's just 12% increase from your baseline FEV1 to your post value. But as I said, if you're using the predictive value, it's much more sensitive, and that's the calculation there with a reference. And I'll share these slides with you. So quality assurance checklist. So you need your minimum 3 technically acceptable blows. So what does that mean? They've all got to look the same. They should all duplicate each other. And the 2 highest pre and post FEV1s need to be within 150 mils if they're over 1 litre. Yes, there's a mistake there. If they're under 1 litre, that should be under 1 litre, they should be within 100 mils. So you can imagine a child might have a lung function, an FEV1 or FVC less than 1 litre. So if it's less than that, it should be within 100 mils. So all 3 peak flows, as in adults, should be within 40 mils. And I don't think this will affect you, but if a child blows out really, really quick, less than a second, then you can use the FEV1 0.75. So if you can imagine, the FEV1 is the frequency of expired volume over 1 second. So if they're blowing less than 1 second, you need to use a different value. So it would be the frequency of expired volume over 0.7 microseconds, and you can find that in your settings. It's not hard to find. I doubt you'll need it though, to be honest, but just if you come across that, children blowing out really, really quick, that might be a thing you need to add in. So your quality checks, you're making sure that your peak flow is rising really, really quickly. There's a smooth expiration down to your baseline without any glottic closures. There's no leaks. There's no early inspiration. You've got your plateau on your volume time curve, and all the shapes are reproducible. So this is, what you would expect in an adult as well. These are some of the problems that you might expect, which you've all probably seen as well. So coughing, swallowing, not putting the effort in, or a hesitant start. These are your definitions, which you all probably know anyway, so I won't go into that. And yeah, this is just an example of obstruction. So obstruction is basically when, so your airway is a tube, isn't it? And if there's something blocking it, then it's going to be obstructed. So there could be lots of different reasons for obstruction. There could be some swelling, could be a tumour, there could be in COPD, the airways are a bit floppy or damaged. So there's lots of different reasons for that, and not just asthma. And in children, potentially you're thinking, it could be asthma with that history alongside the tests, but it also could be bronchiectasis and other things. So if you're not sure and you've got an obstructive spirometry anyway, you should be referring them in. So restriction just means the airways can't inflate, so the lungs can't inflate as much as they should do. And there's lots of reasons for this as well. Have a look at your patient if they've got a curved spine. So in scoliosis, that might be one of the reasons for that. If they're obese, that might be a reason they've got restricted spirometry. You can have problems with the diaphragm as well, that the diaphragm doesn't move up and down correctly, or neuromuscular disorders. But definitely look at the effort. Are they putting the effort in? Are they taking that really deep breath in before they're blowing out? But if the cause is not clear, seek advice and refer them in. And this is just another example, so you can have that mixed pattern as well. So Z scores, hopefully all of you are using these now. Back in the day, so we were using the ratio of your FEV1 FVC of over 70%. So lots of people are still using this, but we're not using this anymore because we know that it will overdiagnose obstruction in the elderly and underdiagnose problems in children. So we always recommend using the lower limits of normal, which is where the Z scores come in. And the Z score is just basically a statistical tool to compare the measured and the predicted values. And it will show you the number of standard deviations from the mean value. I'll show you a picture in a minute, which will make it a bit clearer, but a Z score of less than minus 1.645 represents the point at which only 5% of the population had a value lower than the predicted value, and this is where things become abnormal. So if I show you a picture, it'll probably be a bit clearer. So if you had 100 patients, so this is a distribution curve, so everybody's different, aren't they? So if you had 100 people, they've all lined up, they've all got different shaped lungs, but most people would have a similar shaped lungs if they were of a certain age, gender, and height. So if we say 90% of the population, of that population, would sit in the green area in the middle there. So you've got some outliers on each end. So where it says U at LN, so that's your upper limit of normal. So from that group of 100 patients who were the same height, age and gender, you've got people who've got lung function higher than normal. So that's 5% will have lung function higher than the upper limit of normal. On the other end of the scale, we've got people who have lung function lower than the lower limit of normal. So that's where that minus 1.645 comes in, that magic number. So you can see there's a scale there on the bottom there. So if you, from what minus 1.64, if you go down from there, anything from there is abnormal. And you can see on the right there, you've got FVC, FEV1 and your ratio, so your FEV1 over FVC. So that's how it, so hopefully, most patients will sit within the green area, so they'll have normal lung function for their height, gender and age, but some will sit below and some will sit above the limits of normal. So that's what we're looking for when we're interpreting spirometry. So it's quite hard to explain that, but once you've got your head round it, it does make interpreting spirometry a bit easier. When you, so basically, I'll just go back if I can. Oh, yeah. So if you look at the third bar down, when we're looking for obstruction, we're basically looking for a Z-score of less than minus 1.645 for your FEV1/FVC ratio. When you're looking for restriction, you're looking for a Z-score of less than minus 1.64 in your FVC. So anything in that lower range is going to be abnormal. Hopefully that makes sense. And then if you come across a patient with obstruction, then you can grade the severity based on the FEV1. And these are the categories that are suggested by the ARTP. So this is something I wouldn't be able to tell you off the top of my head because I'm not doing it regularly enough, but I would be checking against the criteria when I'm reporting that spirometry. So once you're, doing it regularly, it's fairly straightforward, basically. So I've got some examples here, so you can interject, or I can just go over them if you like. I'll just check the time. Yeah, we're out of time. So yeah, this one. So if we look at the, we're looking for obstruction to begin with. So we've got a Z-score of 0.22 there, haven't we? So is that obstructed? Is that lower than minus 1.645?
No.
No, it's not, is it? So it's not obstructed.
I
and
can't see the slides, Emma.
You can't see the slides?
I don't know why. I might have done something. I'm a bit thick when it comes to Teams, but I can only see your lovely face.
Oh, okay. I'll send you the slides. I'll talk to you. Oh, sorry about that. Hopefully everyone else
That's
can.
all right.
Yeah. So we're going to look for restriction now. So the FVC is minus 0.19. So is that lower than the lower limits of normal? So is it less than minus 1.645? It's not, is it? So it's normal. So this spirometry is normal. And then if we go to the next one, so this one, you do have a bit of scooping there. So that would suggest that this patient potentially could be obstructed. When we look at the ratio, so the Z-score for the ratio is minus 3.59. So that's less than minus 1.645, isn't it? So that's definitely obstructed. And when we look at the FEV1, it's minus 3.81. So that's lower than it should be as well. And if we look at the severity grading, so this patient's basically got obstruction with a low FEV1, but we want to grade the severity. So if we look at that, it's, what did we say? So it's very severe. So they come into the very severe category because it's less than minus 3.8. Sorry, minus 3.50. Okay. This one here. So this one, the blow doesn't look the best blow, but we'll ignore that for now. It doesn't look quite peaked enough there. So you might want to repeat that anyway. But this one, let's have a look at it anyway. So if we look at the ratio, is it obstructed? No, it isn't. So it's actually, the Z-score is at 0, so it's not obstructed. Is it restricted? So if we look at the FVC, it's less than minus 1.645, so it's set at minus 4.34, so it is restricted. So this patient has got restricted spirometry based on their gender, age, and height. And this is just an example of reversibility. So this patient had good reversibility, and you can see that from the picture. When we use the criteria for Hampshire and the Isle of Wight, this is what we would like you to use. There's a 36% improvement on the FEV1. So I've just put the calculation down there just to demonstrate. So you'd use the post minus the pre, times it by 100, and you divide it by the predicted value of the FEV1, and that gives you a percentage. Okay, so have a look at these in your own time, and that will help. And I'll send you a calculator so that you'll be able to do it more easily as well. These are just some examples of how and why we would use that calculation rather than just using that 12% number. But you can see there, if a patient's lung function is borderline, using your 12% cutoff, using this calculation is much, much more sensitive, and will pick out reversibility much easier. So documentation, when the patient comes in, you need to be asking them, on the day of the test, if they had any inhalers that day, but documenting whether the spirometry has met the quality criteria. So if they're reproducible and repeatable, you can comment on the curves as well. Were there any issues? And then file the report on the notes. You probably also need to get your patient-specific directive or your PGD signed and dotted, and whatever it is you do locally to you. So checking the results. So again, are they good quality criteria? Did they have obstruction? Was there any restriction? Is there any mixed problems there? So obstruction and restriction together at the same time. Did they respond to bronchodilators? So that increase of your 10% of your FEV1. And just remembering, spirometry is not a perfect test. So potentially it might not tell you what you want to tell you, a bit like pheno. Sometimes that's a bit disappointing, isn't it? And what does that clinical history suggest when we've combined it with the objective tests? What is it telling us? Do we need to think about doing some other tests to confirm a diagnosis or referring him? And would an 8-week trial of treatment be of any benefit? And that's basically it in a nutshell. But getting that diagnosis right in children is really important. They could have a lifetime of asthma, so why aren't we doing it in children in the first place? We seem to leave it until they're adults and they're having problems. We do have the worst outcomes for children's asthma compared to most of the rest of the world. So we need to be thinking a bit differently and getting it right earlier on. But a diagnosis of asthma can only be reached with a clinical assessment plus objective tests. And a good response to treatment. And these are my email addresses. Obviously, you've contacted me. I will be leaving this role, but that's my nhs.net email address there if you need it. I'm on several WhatsApp groups as well. And if you are working with children and young people with asthma, there is some national training that we'd encourage you to do as well. That's available on the e-learning for healthcare portal. That's the scan there, and I'll share the link with you. And just to say, if you haven't got this book, this is a really good book as well. Has anyone got these books? No, it's quite expensive. So it was about £45 to buy, but your GP practice may want to buy it. It's produced by the ARTP. I would say you probably need to get a new copy every 5 years because things change. Oh, great, that's good, Lucy. Yeah, things change. I'm telling all this stuff today, but in 5 years' time, it may well be out of date. So that's quite a useful thing to do. So has anyone got any feedback on that?
Might give it a go.
Yeah, give it a go. Honestly, it's really fun doing it in children. They're not that scary.
I'm not sure I'd describe it as fun.
Oh, I think it's
But
fun. Yeah,
I might give it a go.
give it a go. I
Do you
promise you,
like
you'll
it,
be
do you?
fine. Yeah, yeah. I
Yeah,
mean, you can get. I
I'll give
mean,
it a go.
like I said, I did a spirometry clinic yesterday with some adults, and they weren't very good at it. And actually, that when we had a meeting last week, somebody had already been doing pediatric spirometry, and she said actually it's a lot easier doing it in children. So you have to pick your
Oh, interesting.
children a bit, but
Yeah,
when you do
okay.
it in adults anyway, it can be tricky, can't it? So,
Oh, yeah,
um,
yeah, for sure.
yeah, and at least you're only concentrating on doing the force blows, so I think that's
Hmm.
quite good as well, isn't it?
Yeah,
Yeah, so it
okay,
should be fairly straightforward.
okay.
Um, but everybody's different, aren't they?
Yeah.
Yeah, but where are you doing it at the moment, Tina?
In Winchester at St Clement's.
Oh, right, you're still there. So you're getting
Yeah,
through that backlog.
yeah.
That's
Yeah,
good.
yeah. No, I mean, I cleared the backlog a long
Oh,
time
well
ago,
done.
but um, yeah, the GPs, at the moment I'm just telling the GPs that I don't do it, and because I did the adult ARTP and I'm on the register, I kind of felt that I had to do the pediatric, and I was like, no, I can't be bothered to do the
Yeah.
pediatric. I just won't do it. But if you think it's okay
Mm,
for some, because I've got the ARTP adult interpretation
yeah.
performance, and I've been doing it for years. So
Yeah. It's not, it really isn't
yeah, I
much
don't think I'd feel
different.
bad about giving it a go on the children.
No. I mean,
Right, okay.
if you're
Might give it a little
new to
go
doing
then.
children, do it on, start with the 12 and over.
Yeah,
They'll follow exactly what you say. Honestly, you'll probably find it really, really easy. And then work
yeah.
your way down to the younger children.
Downwards, yeah,
Probably the best way of doing it. The younger children
yeah.
obviously can be a bit more challenging if they're a bit fidgety, and but they are, I really like working with children, and
Mm,
you know, like yesterday we had a load of really elderly people come in. And I think, what is the point of doing this half the time anyway? Um, do you know what I mean? Though, when they're in their 80s and you're
yeah.
thinking, is this a bit cruel and what are we achieving here? Um, Whereas actually, your parents will really appreciate it if you do those tests for them.
Mm,
If you are in Winchester and around that area, obviously Andover are going to be opening for paediatric spirometry
yeah.
sometime
'Cause-
this year. So if the parents are willing to
yes.
travel, that might
Yeah,
be
yeah. But you'd be surprised
um,
at the amount of people who will not go. Yeah, yeah.
yeah.
But yeah, no, that would be really useful because the Andover service is excellent. Yeah,
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 yeah, it's quite good. And you're really lucky actually, that you can refer to Andover. The rest
yeah.
of Hampshire is not doing very well in terms of services, so that's really good.
Mm,
Yeah, you're
yeah.
quite lucky. Anyone else want to give it a go with children? Hopefully you do because you're here. I'll stop the recording.
Yeah, I've been doing a few children, older children, I would say. I quite enjoy it, yeah.
Good. Well, that's good.
Um,
Yeah, they're
yeah,
nice, aren't
I
they? I
don't
like
mind it at
children.
all.